introduction, and again, a warm welcome from all of us on behalf of the BC Centre for Palliative Care and joining us at this ECHO session. Today, recognizing that there's a various level of learning and capacity in each one of you, I hope that these two learning outcomes would apply to you, that by the end of today, you would have an increased understanding of the compassionate communities concept and be inspired to explore collaborations, new strategies to work collectively with other communities in action. Again, this is really a learning initiative and opening conversation about compassionate communities. Just a note about the BC Centre for Palliative Care, as most of you know probably who we are. Next slide, please. We were established in 2014, and the BC Centre works with both health system and community organizations, bringing stakeholders together to help identify and accelerate the spread of best practices in palliative care. And we do that by integrating a palliative approach to care, to support chronic disease management and care through the health systems. We do that by reorienting in this public approach to care, reorienting health systems that are closer to home, strengthening community role and capacity, and in doing so, support environments and create support environments for both families and patients and caregivers. And lastly is to help develop individual skills to cope with illness. So in a sense, it's an ecosystem of what we're doing, and all of these are important parts in a palliative approach to care. Compassionate communities is a public approach to care, and especially focusing, reorienting care closer to home and creating the supportive developments for patients and their families. We hope that that will become clear throughout this presentation. Next slide. As you know, and some of you were very aware of, but perhaps not able to attend, the inaugural BC inaugural Compassionate Communities Symposium that happened last year, September 2022. Our keynote speaker was Dr. Gillian Abel. He has spent his clinical life as a palliative care physician and specialized really with an interest in compassionate communities, initially as part of supporting people undergoing the experiences of death and dying, loss and grieving and caregiving. And over the last many years, he has worked with and has now become actually Compassionate Communities UK medical director and the executive director. But the pioneering work was done originally with the Frome Medical Practice, which is a community in England, applying Compassionate Communities approach to healthcare and with some really startling results. So today we're going to explore this concept a little bit more. We recognize there may be way more to unpack than what we have time for here. And we're focusing on what was captured in the book, primarily the Compassion Project. You were also invited, if you had time, to either read the book, or perhaps you were able to view his TED Talk, or read one of the other pre-readings that we were sending you in an email prior to this. But compassionate community begins not with the imposition of an ideology, but with the cultivation of the active power of compassion with individuals. That is the key to this. The key of compassion was shown in a context of research. Next slide, please. As shown by Dr. Abel's work and the science that was represented in this chart here. So with the impact of interventions from the risk of dying, predominantly for those who were suffering in the study, were suffering with high blood pressure or hypertension. So take a look. You may have seen this on the preamble video, but I'd like to share it for everyone once again. The second line from the bottom is red. The bottom indicates the use of drug interventions for high blood pressure or hypertension. So the red indicates that there was indeed a success in mitigating the risk of dying and prolonging life. The drug treatments were effective. However, this study also showed, if you look at the top three bars, the astonishing outcome showing the impact of the treatment for hypertension by social relationships. All three of those lines, social relationships, were showing off the impact of treating high blood pressure with a remarkable, staggering impact. In fact, it says social relationships are proven fundamental to human health. And the impact of benevolent context, which is kindness, compassion, connection, have a greater effect on extending the life of more than one measure of sensation, including the sensation of stop smoking, cessation of alcohol, maintaining a healthy diet, increasing your exercise, treatment. All of these were surpassed by social relationships. The key to health was relationships. And indeed, in this study, loneliness and social isolation as risk factors for mortality, this review, we see as humans, we spend 95% of our lives developing relationships. This is the context of our health. So the question is, as Julian Abel posed, how do we embrace compassion, enlarge social relationships to improve our health and well-being, especially now in this context, in our current epidemic of loneliness, social isolation, aging impact, complicated, complex illnesses and diseases. The study that is highlighted in Compassion Project by Dr. Julian Abel, next slide please, was developed and pioneered in Frome. Frome is a community in England. As you can see there, it was a population of this community was about 28,000 people, and Frome's catchment area is about 100,000 people. I don't know, is that maybe the size of Courtenay, Comox? I'm not sure. However, in this context is where community began. So with referrals from physicians and other community supports, the relationships were built for addressing the needs of individuals, healthcare needs, social cycle well-being. Next slide. The key elements that were developed in this compassion model were the following. As family physicians identified patients who needed community support. So when a patient would arrive with mental challenges or mental impairments or loneliness or social isolation or depression as a diagnosis, not only was there a medical recommendation made with medical support, but more importantly were referrals to how can we get you connected into community. Frome's model used the talking cafes as the primary connector. Many individuals would say that they were not ready to go to an activity. So the talking cafes provided a place where people simply wanted to go for social interaction, perhaps a Tim Hortons kind of model. Instead of those activities, what happened in those conversations was that people often became aware of and became highlighting each other's needs. So it became a discovery process of what would mean more for one another in this cafe. Cafe provided it, but also out of that, the researchers discovered other needs that could be addressed or other areas that could be developed to support families and individuals. From that, excuse me, the database of existing supports and volunteers was derived. What did the community already have in place? Perhaps it was a place for volunteering. Perhaps it was a place for meals. Perhaps it was a place where you get your hair cut or at the barber shop. That raised the next area, which was connections to volunteers and services in their areas. From that database to see what other capacities or assets were in this community. And then recommendations from the group for a hub. The hub was indeed the database connection. Excuse me. The Compassionate Communities model also trained and developed over 1,000 community connectors. They were trained to signpost or wayfind or whatever the word might be. This included the hairdresser, the shopping center checkout gal, the pharmacist, the assistant. Perhaps it was a waitress or an owner at a cafe or a restaurant. Anyone could signpost resources. And where they discovered no supports were in existence, there was the formation of other networks of support on what else is needed. Next slide. The definition of a community, a compassionate community, is this. It is a community where people intentionally support one another during serious illness, end of life, and grief. And a community where people plan in advance for the way they want to be treated and cared for during serious illness and near end of life. In other words, a compassionate community empowers people's voices in their own care and helps them to live well with dignity right until the end. The essence of a compassionate community is twofold. People are motivated by kindness, by compassion, and take action and responsibility to care for each other. Next slide. The Frome model that was exercised was in the district of Mendip. Here were the essence of their model. It was community-led and community-driven. So in other words, it was in the community by the people, about the people, for the people. And in that community, there was the development of assets, looking at assets. By that, I mean, what are the things that are already in the community? As described by Julian Abel, what were the resources? What are the treasures? What do you already have as services existing in the community? Not from a deficit model of, oh, we don't have enough, we don't have this, we don't have this. What do we have? We're really rich. Maybe it's an artist. Maybe it's meal planners. Maybe it's a car service. Maybe it's car repairs. Maybe it's home visits. What do we have? Let's take a look. And they did that and started to map their assets as an organization and as a community. Then from that mapping, they could address the gaps in the services. And from that, developed a reliable, accessible, searchable directory for everyone. And again, the effectiveness of this approach to care and compassion is that assets, services, and adaptations were designed by the people who do the work, were familiar with the work, and then applied reliably across the whole of the community. Next slide. The key element for helping ignite, if you will, the communication are community health connectors. We may know them again as community connectors, wayfinders, senior connectors. There's many, many different names for this. In the Frome model, it's community connectors. It was very similar to the role that we would now say the volunteer has in the NavCare program in British Columbia. So these community connectors were trained and supported volunteers who then were able to use their ability, their skills, and their experiences with people to help transform the health and well-being of individuals in their community. Community connectors connected to people to get involved in social activities, created groups, meeting their needs, signposting them to relevant other supports and services, also in the community proximity, and essentially are champions of health and health choices, seeking to move away the barriers and created supported networks and environments for others in their community. Next slide. Quick summary shows here, again, the key elements. They're essential. The service directory, community connectors, the groups that are formed, and health connectors to community promotions. So we can actually do more for our health by improving the quality of relationships with the world around us than by making any other change we know. Julian Abel advocates over and over the creation and preservation of good health is relationships, relationships, relationships. Not just breadth, but depth. The assets and networks that support those are intentional, and they incidentally grow from the warmth, laughter, and friendship of others. So motivated by kindness and compassion is the well-being of others. And you and I probably all know that. And indeed, Frome harnessed the power of interrelationships, of health and social welfare. And the healthcare service, which was and affordable in its own costs, was actually integrated then into a wider pattern of daily community life. Pragmatically, compassion isn't the only way to alleviate suffering, but it also demands a clear-sighted acknowledgement that the limitations of our existing health system seek to employ strategies to creatively and practically develop assets that are for the well-being of all. So we can acknowledge that the role of compassion in our lives and begin to take the advantage of the rich resources we have. This is proven And Fromm led in a great model to show that the benevolent power actually empowers the quality of life and reduces the chances of spending our last days alone in a hospital ward. The results are shown on this next slide. The Fromm project was the first project to attract serious national and international attention because it was the first project to record a measurable reduction in emergency hospital admissions across the population. It offered the potential to a mass problem battering the Western health systems, such as ours. So over the 4-year period from 2013 to 2018, hospital admissions in Fromm were down on the left side by 15%, while in Somerset on the right, rose nearly 30% in the same period of time. Compassionate communities is not a medicine. It's not a drug. It's relationships and connection. By this, we would say, in the work that has been done thus far and continues, everyone has a power of choice. Choosing kindness and compassion, whether a healthcare provider in any capacity or as an individual of our communities, laughter, friendship helps us live longer and be healthier. So what happens if everyone in our community were to choose to show a little more kindness? Let's just say, next slide, compassionate communities, something that was sparked by 2013 by Dr. Alan Helig Kelleher, has spread across the globe and is moving rapidly. It is a movement. The key principle to the understanding of compassionate community and a growing health phenomenon is that community is an equal partner in the provision of healthcare and social supports at the end of life. Next slide. Reiterating again, why is community an equal partner? Because each one of us will likely experience illness, death of a loved one, caregiving for a loved one, dying ourselves, grief throughout our journey and the journey of others. We spend 5% of our life interacting with a healthcare professional, 95% of our life in community, with our family, with neighbors, in our jobs, in our world. The communities in which we live are rich, and we have rich social assets and skills and talents at hand. People in community can be equipped and prepared to help one another during these life experiences to live the best possible way possible. Compassionate community is an approach to palliative care, a non-clinical approach to palliative care. It engages and empowers communities and citizens to take responsibilities in the provision of supports that address social and emotional dimensions of the illness experience for the patient, the family, the caregivers in our community. Let's assess and connect and mobilize what already exists. At this time, I'd like to give everybody a chance, as we have promised you, to move into breakout groups. And there's a couple of questions you will be asked to consider. We know that the best way to design is to talk with one another and already acknowledge that we're already part of communities in our workplaces, in your field of research, as a policymaker, as a caregiver, a volunteer, and as a spouse or a family member. For you to share your ideas in the next 15 minutes, consider these 3 questions. What's most intriguing or inspiring about these few moments that we shared with you, compassionate communities, about the concept and the principles? Could you envision any opportunities in your organization, in your role, in your community to be more collaborative? Are there ways to form partnerships with others? What could that look like? And lastly, what resources and supports would you need to help shape and expand compassionate communities? Okay, so we'd like to take a few minutes to hear back from you, from your input from your groups regarding these 3 questions. So I'm just going to call facilitator, and I'll start with Rachel. Would you like to share what your group's answers were to some of these questions?
Yeah, thank you. Big thank you to everyone in my group. Everyone shared some really interesting thoughts. I think what we concluded was the biggest thing that was the takeaway was in relation to the resources and supports, as well as like knowing there's sort of like having stuff around the concept of compassionate communities. There was a real desire for informational resources that really look at the practicalities of it. What does it actually look like? What does it actually mean to do this? Both for people that are already on board and might want to have more information about how can I go about doing this, and some really great like specific suggestions around things like, well, what does it look like if you are, and then different types of people, how it might look if you're a neighbor or a teacher or and things like that. So there was just this really big emphasis on the bite size and practical information of what does this actually look like in practice.
Okay, excellent. It's a great start. Thank you so much, Rachel, and your group. Josh, can I invite you to share?
Yes, like once again, also thank the group for speaking and for me not to be in silence the whole time. And so that was great. And so, yeah, a couple things that were mentioned was that a lot of this is part of the practice within organizations that they're already working with. But people did speak about the surprising effect of compassion. And it's like, I think it's just, we don't understand what the effect we're actually having on people. That it can actually have such a drastic effect on hospital visits or, you know, like their health moving forward. So that was really nice. And then what people would like to see moving forward, some of the stuff is to really try to, especially in a hospice, to try to get families and even patients to come together more and have compassion towards each other more would be helpful. A lot of times the hospice will set up different events, maybe pancakes or a dinner, and people can sort of meet each other, but usually they don't have events where they can meet each other on a regular basis. So that's kind of interesting to think about moving forward. Also, there's some gaps that they sort of people have talked about in maybe raising awareness at the hospital of different programs, and also just raising awareness of programs in general in the community. And then also what people need, and I guess allowing programs to have that ability to ask different individuals what they need. And so it's like getting people to programs to, I guess, service them or help them, support them, and then also then getting people to understand what services are available to volunteer and also to support.
Sounds like a great discussion was happening there. Thank you, Josh and group. Appreciate it very much. I'm going to move up to Lisa. Would you like to share your group's work, please?
Yeah, so just thank you to the group again. I actually learned some things I'm deeply appreciative of. So what we did discover is that a lot of this work is already being done in community. So there was appreciation of recognizing that organizations and groups are doing this work. And then it's moving, this movement is moving globally too. And that's coupled with the realization that healthcare cannot meet or sustain a demand for these types of supports. So that was a really great takeaway. For resources and support in order to help do this work, there was some good conversations about having a network of care, being able to connect with other organizations and share information and resources. There tends to be a lot of duplication. You know, people are working in silos. The problem exacerbated a bit more after the pandemic. More community partnerships, so you're not reinventing the wheel. So an opportunity to really connect with one another and do exactly what we're doing today, learn and share resources from one another. Another piece brought up was partnerships with local doctors to ensure the consistency of the information. Someone brought up the Systems Navigator project that was at Fraser Health. It was a pilot project. So just something that can really put together like a database or repository of resources that people can find easily. And this tends to be a challenge, particularly in the rural areas where it tends to be just one person doing this work. And a really interesting point too that I really found interesting was, what do we define as community? Like, it doesn't mean the same thing to everyone. So the languaging at times doesn't seem to be consistent. And the other big issue was about volunteers and people to actually help do this work. So how can we work together to, either obtain new volunteers, or how do we get paid staff to assist, particularly when it's a rural organization? How do we attract volunteers? Like, how do we bring people from perhaps outside of hospices and other organizations to come in and really help build and spread this movement?
Okay.
Good.
Fully loaded conversations. Great insights. Thank you for sharing that. I'm going to move on to Jazz.
Yeah, sure. Thank you, everyone that was in my group, for your input as well. So we started out with looking at actually appreciating that slide that you shared, Melody, the one on the reduction in admissions. And so I think they felt that was really good evidence for continuing to do this work. And then we looked at just volunteers and the use of volunteers, like for people that are that don't have the family supports and they're lacking those supports at the end of life, and maybe they're not able to leave the home, having volunteers to visit people in the homes. And that led into a conversation around just the difficulties that we've had in terms of recruiting volunteers post-COVID, and how there needs to be more resources put towards volunteer coordination and recruiting volunteers and helping volunteers feel safe in volunteering. We had a great example of partnering with other organizations. I'm sorry, the name of it's the Squamish, I think it was the Squamish Hospice had partnered with someone in Whistler, and the library had given them a space. So, the three of them came together, partnered, and did a beautiful collaborative, compassionate community project. And then we closed by kind of just saying, like, that, just know your community. If people aren't willing to come in, maybe we could do programs through Zoom, but then there will be communities that prefer the in-person kind of contact. That's
Okay.
it. Thank you.
Thanks so much, Jazz, and to everyone in that group. We recognize that 15 minutes hardly scrapes the surface of anything, nor does this 1 hour even touch it, but it sounds like we've opened all the Pandora boxes we possibly could. And just to reiterate again, the possibilities are amazing and the need is great. So Tina, would you like to share your group work as we round out here?
Sure. So I, as everyone has said, I'd like to thank the group. I also want to acknowledge that for me personally, it was very exciting because I had a very mixed group of participants. So I had folks from hospice, I had some from municipality, and I had 2 social workers from Island Health. So for those of you that wonder why I'm getting excited about this is something we've really been striving to achieve with these echoes, is to have that wide representation from community through to health systems. So that was exciting for me. One of the things that was talked about was a really good example of how to do some collaboration and learn about the other organizations or services that are in your community. One of our group members is in Nanaimo, and what they do is they monthly bring and invite in another organization from the community to meet with their volunteers and with their staff, and to describe what services they offer, and then for them to discuss how there might be overlap and support they can offer across each other. They have a directory, the seniors directory, that is already very full and fulsome, but this really seems to bring it to life, to give people that better understanding of where those connections can happen. I thought that was really exciting and a good practical example of how you can connect with the others in your community. One of the other things that I think came up around the whole idea is finding that balance for not overwhelming patients or clients with all of the possible resources that are available to them, and meeting them where it matters to them. So finding a way to not just not just ask them what they need, but also to connect them with somebody that through probably, I would describe it as relationship building, would help to find what supports and services might be of benefit to them.
Okay, fabulous. With great thanks for the 58, I think, participants we had on this ECHO, which is fabulous. Just want to reiterate, this is really our first ECHO post the symposium because we knew there's a lot of interest. We've probably talked about things and have no further direction right now. We will follow up with an email